Hello everyone, I am Dr. Omkar Sangita Diliprasonone from team AFMG, and today I am back with a very important and high yield topic from the subject of anatomy as well as orthopedics. But before I begin and jump into this session, I want to highlight some important points. First of all, the last regular batch of AFMG is to begin soon. Therefore, if you have not enrolled yourself, please make sure that you enroll yourself by contacting AFMG via the social media handles or the numbers given in the description below. Apart from that, also do not forget to join the AFMG Telegram group. So over there, you will get an ample amount of MCQs to practice daily. Along with that, also just download the AFMG app from App Store or Play Store, and there also you will get a lot of recorded video lectures as well as you will also get a lot of MCQs to solve. Also with that, AFMG has begun already its test and discussion sessions, so make sure that you enroll in these test and discussion sessions as well, where there would be multiple number of tests and discussion for each and every subject, along with some mini mock and mock test, which will include discussions by not only the team AFMG but also by various esteemed faculties, which usually takes all the lectures in AFMG. Okay, so with this, I will also like you to just subscribe to the AFMG YouTube channel where you are watching this video. So please make sure that you subscribe to this channel so you will all get the regular updates about all the videos uploaded, not only regarding all the high yield topics but also each and every session that AFMG will undertake hereafter. Okay, so just make sure to subscribe. Now, talking about today's session, guys, this session will mainly focus on a high yield topic of anatomy as well as orthopedics. So usually it is a topic of anatomy and has its applied aspects in ortho. So this is a very important topic, brachial plexus and the nerve injuries related to it. Okay, so let's begin. So first of all, if we talk about brachial plexus, guys, so please remember plexus means a network. Okay, and what do we mean by a brachial plexus then? So please remember, brachial plexus is just a network of the ventral nerve roots. I hope it is quite clear with everybody that from vertebral column there are some nerve roots which exit. Okay, these are known as your spinal nerves. These spinal nerves usually has some ventral nerve roots and also the dorsal nerve roots, but brachial plexus is only and only made up of these ventral nerve roots. So please remember, always they can ask you, brachial plexus is only made up of ventral nerve roots, not the dorsal one. Okay, now these nerve roots, that is, which range from C5 till T1. Okay, so please remember the root value if they ask for your brachial plexus, it is C5 till T1. That means C5, C6, C7, C8 and T1. All of these come together and form the brachial plexus. Right, now these roots, just imagine brachial plexus is nothing but a tree. Okay, so it will have its roots which will come together and will form trunk. Then these trunk will divide into divisions, and then these divisions will again come together to form some cords, and finally these cords will have its branches which are known as your peripheral nerves, which will innervate some individual muscles. Right, so likewise we'll study the brachial plexus. So just to give you an overview, this is a complex picture. I'll simplify it further so you can just get an overview from this picture of how your brachial plexus is actually. So here you can see from the vertebral column the nerve roots are exiting, and so it has a dorsal root and a ventral root. So all of these ventral roots are coming together to form the brachial plexus further. Right, so if I talk about brachial plexus, it is comprising of the nerve roots C5, C6, C7, C8 and T1. Right, so these are your roots which combine to form your trunks. Finally, these trunks then divide into anterior and posterior divisions each. Then they further divide or come together as cords, and finally they divide and redivide into its terminal branches. Okay, just understand this concept now, then I'll explain you it one by one. But first of all, now I would like to know that the roots, first of all, please remember they are located in the neck just aside to the vertebral column, whereas the trunks, they are usually located in the posterior triangle of the neck. So the question can be, what is the location of your trunks? So please remember the trunks are located in the posterior triangle of neck. Whereas the another question can be, where are the cords located? So please remember the cords and some of the important branches, these are located in the axilla. So please remember the cords are located in the axilla, and these cords come together and form the nerves in the axilla itself, right? Next, if I talk about the direct branches. Now to understand direct branches, you can see over here that usually the nerve roots come together, then trunks, then divisions, then cords, and finally there are some branches either arising from the cords or the terminal branches. But there are some nerves which directly arise from the nerve roots itself, okay, like this one or this one. So these are the two nerves which directly arise from the roots. So now the nerves which are direct branches of the roots are two important. One which directly arises from the C5 nerve root, this is known as your dorsal scapular nerve. So please remember, the one which arises from the C5 nerve root is known as your dorsal scapular nerve, which is also known as nerve to rhomboidus. Why? Because it innervates your rhomboidus major muscle as well as your rhomboidus minor muscle, and also with that it also innervates your levator scapulae muscle. So please remember, the first nerve which arises from the C5 nerve root directly is dorsal scapular nerve. Next, the nerve which arises from nerve root C5, C6 and C7. So it has contribution from C5, C6 and C7 nerve roots. This is known as your long thoracic nerve. Okay, this is known as your long thoracic nerve. And this long thoracic nerve also has another name. This is also known as the nerve of Bell, or Bell's nerve you can call it. Okay, this nerve usually innervates, or it supplies the serratus anterior muscle. It innervates the serratus anterior muscle. So please remember, the direct branch of C5, C6 and C7 nerve root together is known as long thoracic nerve or nerve of Bell, which supplies the serratus anterior muscle. Okay, if there is any injury to this long thoracic nerve, there would be paralysis of the serratus anterior muscle, and that can cause winging of scapula. That we'll discuss further. Okay, next, now just like this, the dorsal scapular nerve or the long thoracic nerve arising from the nerve roots, we have some direct branches from the trunks as well, and they are mainly seen from the superior or the upper trunk. So the direct branches from the upper trunk are two again. First is a nerve to subclavius. So this will finally innervate the subclavius muscle, whereas the another is your suprascapular nerve, which will innervate two muscles. First is your supraspinatus muscle, and second is your infraspinatus muscle. So please remember, the two direct branches from the upper trunk, these are your, first is nerve to subclavius and second is your suprascapular nerve. These two branches. Okay, so please remember these. Now moving further, just simplifying the brachial plexus altogether. So this is the easy diagram that you can remember. So first of all, if we talk about brachial plexus, as we said, it is a combination or a network of the ventral nerve roots from C5 till T1. Okay, sometimes it can be C4, sometimes it can be T2 as well, but mainly it is C5 till T1 only. Okay, where the C5 and C6 nerve root come together to form the upper trunk. The C7 nerve root directly forms the middle trunk, and the C8 and T1 nerve root come together to form the lower trunk. So once again, C5 and C6 together forms the upper trunk, C7 directly forms the middle trunk, and C8 and T1 come together to form the lower trunk. Right? So we have three trunks with us: upper, middle and lower trunk. Then now these trunks would be divided into divisions. So please remember, each of these trunk is divided into anterior and a posterior division. Okay, each of these trunk is divided into a anterior and a posterior division. Now further, these divisions will come together to form cords, right? So please remember, the anterior division of the upper trunk and the anterior division of the middle trunk, they come together to form the lateral cord. So please remember, anterior division of the upper trunk and the anterior division of the middle trunk come together to form the lateral cord. Next, the anterior division of the lower trunk directly forms the medial cord. The anterior division of the lower trunk, it alone forms the medial cord. It does not combine with anything. Whereas the posterior division, so please remember, the posterior division of each of the trunks, they together combine and form the posterior cord. So this is easy. All the posterior divisions combine together to form the posterior cord. So we have 3 cords with us: the lateral cord, the medial cord, and the posterior cord. Now this 3 cords will have its branches further, so that is difficult to remember, so you can just remember it by a mnemonic. So let's study those mnemonic and the individual nerves further. So now, first of all, if I talk about the branches from different cords, as we discussed, there are 3 cords: lateral, medial, and the posterior cord. Now the lateral cord has 3 nerves arising from it. Those can be remembered as LML, where first L goes for your lateral pectoral nerve. By the name itself, you can remember the lateral pectoral nerve would innervate or supply the pectoralis major as well as the pectoralis minor muscle. M goes for your musculocutaneous nerve. So please remember, the musculocutaneous nerve is the very important nerve which innervates the anterior compartment of the arm. Okay, and last, L goes for your lateral root of the median nerve. L goes for your lateral root of the median nerve, please remember. So now if we talk further about the medial cord now, and the branches of the medial cord can be remembered by a mnemonic known as M4U. Okay, first 2 M are just the medial aspects of the above 2 nerves. Okay, so first M would go for the medial root of the median nerve. Okay, first M goes for the medial root of the median nerve. So by this you can understand that median nerve has 2 roots. Okay, a lateral root arising from lateral cord and a medial root arising from the medial cord, and these 2 together form the median nerve finally. Okay, so please remember, the next M would be your medial pectoral nerve. The next M is your medial pectoral nerve, again supplying the pectoral muscles itself, pectoralis major as well as pectoralis minor muscle. The third M is your medial cutaneous nerve of arm. Okay, it is your medial cutaneous nerve of arm, whereas the fourth M is your medial cutaneous nerve of forearm. Okay, it is your medial cutaneous nerve of forearm. So what do we need to understand from this is, please remember, cutaneous means skin. So these cutaneous nerve will usually supply the skin. The medial cutaneous nerve of arm will supply the skin over the medial aspect of the arm, whereas the medial cutaneous nerve of forearm will supply the skin over the medial aspect of the forearm. Right? Please remember this. And now last U, the U goes for your ulnar nerve. Okay, so please remember, ulnar nerve is an important branch of your medial cord. Right? U goes for your ulnar nerve. Moving further, if I talk about the posterior cord now, so in posterior cord the mnemonic is lunar. Okay, so where L first of all goes for your lower subscapular nerve. Okay, lower subscapular nerve. Now please remember, the lower subscapular nerve, it usually is responsible for innervating the lower part of your subscapular muscle. Okay, so please remember, it innervates the lower part of your subscapular muscle, whereas it also innervates your teres major muscle. It also innervates your teres major muscle. Moving further, U goes for your upper subscapular nerve. U goes for your upper subscapular nerve. It innervates the upper part of your subscapular nerve. Then N goes for your nerve to latissimus dorsi. N goes for your nerve to latissimus dorsi. I hope all of you are pretty clear with this, that the latissimus dorsi is a back muscle and it is also known as the climber's muscle because it helps in climbing. Okay, so latissimus dorsi is also known as the climber's muscle, also known as the swimmer's muscle. So please remember, and the nerve innervating this latissimus dorsi muscle is known as nerve to latissimus dorsi or the thoracodorsal nerve. So this is important, it is known as the thoracodorsal nerve. Whereas A goes for your axillary nerve. Okay, so please remember, A for your axillary nerve, which is also known as your surgeon's nerve. And lastly, R goes for your radial nerve. So radial nerve is a very important branch of your posterior cord. Right? So please remember these. So these are the branches of the cords. So just revise it once again. Lateral cord LML, L for lateral pectoral nerve, M for musculocutaneous nerve, L for lateral root of median nerve. Medial cord M4U, first M for medial root of median nerve, second M for medial pectoral nerve, third M for medial cutaneous nerve of arm, fourth M for medial cutaneous nerve of forearm, and U for ulnar nerve. Posterior cord again 5 branches, L for lower subscapular nerve, U for upper subscapular nerve, N for nerve to latissimus dorsi or thoracodorsal nerve, A for axillary nerve, and R for radial nerve. Okay, so these are the important branches from the cords. Now if I talk about further, talking about some applied aspects from orthopedics, now talking about Erb's palsy first. Okay, on this questions have been repetitively asked. So please remember, in the upper trunk actually there is a common point where the 6 nerves meet together. Okay, so please remember, you can see over here there's a common point where the 6 nerves meet together, and this is what is known as the Erb's point. So please remember, this is what is known as your Erb's point, where 6 nerves meet together. And this if there is any injury to this Erb's point, there would be a lesion known as your Erb's palsy. So please, moving further, talking about Erb's palsy. So please remember, Erb's palsy is due to any injury to your upper trunk near to your Erb's point. So please remember, Erb's palsy is due to any lesion or injury to the Erb's point which is located in the upper trunk. And upper trunk, the root value is C5 and C6, right? Important. So any injury to C5 or C6 nerve roots at the Erb's point can lead to Erb's palsy. Now the causes of Erb's palsy, they can be two important causes. First of all, a fall on an outstretched hand that can lead to this injury, or due to some obstetric complication or birth injuries like shoulder dystocia, there can be injury to this aspect of the brachial plexus, right? Now talking about the attitude of limb. So please remember, whenever a child presents or whenever a patient presents with Erb's palsy, the attitude of limb is very important. First of all, at the shoulder joint, you can see there is adduction, okay, and there is a medial rotation. So please remember, at the shoulder joint there would be adduction, and second thing, there would be medial rotation. Next, if you can see, at the level of the elbow joint there is extension. So there is extension at the level of elbow joint. Next, if you can see, at the level of forearm, there is pronation, okay. And lastly, please see, at the level of the wrist there is flexion, there is a flexed wrist. So this is the attitude of limb in cases of Erb's palsy, and this has been asked. So there is adduction and medial rotation at the shoulder joint, there is extension at the elbow joint, pronation at the level of forearm, and flexion at the wrist. And this is what is actually called as your waiter's tip deformity, or your porter's tip deformity, or your policeman's hand. Okay, so please remember, this is what is known as waiter's tip deformity, porter's tip deformity, or your policeman hand deformity, which is a feature of your Erb's palsy, right? Now if I move further, talking about winging of scapula, another important image which has been repeated multiple times. So if I talk about winging of scapula, guys, as we discussed earlier, winging of scapula is due to injury to the nerve of Bell, which is also known as the long thoracic nerve. It is due to the injury to the long thoracic nerve, also known as the nerve of Bell. And this nerve of Bell or long thoracic nerve, it innervates which muscle? It innervates your serratus anterior muscle. So there would be paralysis of the serratus anterior muscle if there is any injury to nerve of Bell, right? So please remember, serratus muscle paralysis can lead to winging of scapula. Okay, and this is what a picture of winging of scapula looks like. Please remember this, right? Next, if I talk about Klumpke's palsy now, so please remember, Klumpke's palsy is in it closely can resemble Erb's palsy, though the features are completely different. So please remember, Klumpke's palsy, the injury in Klumpke's palsy, it would be to your lower trunk. So please remember, if there is any injury to your lower trunk, where the root value of which is usually C8 and T1. So if there is any injury to your ventral roots of C8 and T1 or your lower trunk of brachial plexus, that can land up the patient in Klumpke's palsy. The cause of Klumpke's palsy can be hyperabduction. So please remember, cause of Klumpke's palsy can be this hyperabduction. Along with that, it can also be due to some birth injury, just like the Erb's palsy. This can also be caused due to some birth injuries like shoulder dystocia, right? Whereas the attitude of limb in Klumpke's palsy would be this. What can be seen over here? So please remember, we can see a complete claw hand. We can see a complete claw hand. We can find there is flexion at the distal interphalangeal joints, mainly at proximal as well as distal interphalangeal joints in all the fingers. Okay, and this is what is known as a complete claw hand, which is due to injury to your median plus ulnar nerve. So please remember guys, median plus ulnar nerve injury can cause a complete claw hand. Isolated ulnar nerve injury leads to a partial claw hand. That was a picture in December right now. Okay, so please remember, this is a complete claw hand seen in Klumpke's palsy. Now, Erb's palsy has a good prognosis. It is more commonly seen. On the other hand, Klumpke's palsy has a poorer prognosis and it is less commonly seen. Right? So please remember, these are the three important applied aspects you need to remember. Now, if I talk about individual nerves that are very important. So, first of all, I'll talk about the musculocutaneous nerve. Now, as we discussed, musculocutaneous nerve, it arises from the lateral cord. Now, they have asked always about the root values of these important nerves at least. So, please remember, the root value of your musculocutaneous nerve, as it arises from the lateral cord, it is C5, C6 and C7. So please remember, musculocutaneous nerve root value is C5, C6, C7. Okay. Now, if we talk about musculocutaneous nerve, as we already saw that it innervates the anterior compartment of the arm. So there would be some motor branches and some cutaneous or sensory branches. Right. So the motor innervation of musculocutaneous nerve can be remembered by the mnemonic BBC. Okay. It innervates your biceps muscle, first of all. So please remember, it innervates your biceps muscle. Second, B goes for your brachialis muscle. It also innervates your brachialis muscle. And C goes for your coracobrachialis muscle. Third, it innervates your coracobrachialis muscle. So these three are the motor innervations of musculocutaneous nerve which are present in the anterior compartment of arm. Next, if I talk about the sensory or cutaneous innervation of your musculocutaneous nerve, the terminal branch of musculocutaneous nerve would be responsible for sensory innervation, and that is your lateral cutaneous nerve of forearm. Okay, so please remember, lateral cutaneous nerve of forearm is the terminal branch of musculocutaneous nerve. So by that we understand that any sensations of the skin over the lateral aspect of the forearm would be carried by the branch of musculocutaneous nerve. Right? So please remember this. Now, moving further, talking about the axillary nerve, which is a very important nerve. So please remember, axillary nerve, as we saw, it is also known as the surgeon's nerve. It is also known as the surgeon's nerve. Let's see why. So please remember, first of all, axillary nerve arises from the, axillary nerve arises from the posterior cord of the brachial plexus. And what is the nerve root of axillary, what is the root value of axillary nerve? So please remember, the root value of axillary nerve is C5, C6. The root value of axillary nerve is C5, C6 and it arises from posterior cord of brachial plexus. Now, the axillary nerve is in close relation to the surgical neck of the humerus. So please remember, the axillary nerve is in close relation to the surgical neck of the humerus. So if there is any injury or fracture at the surgical neck of the humerus, that can lead to injury to the axillary nerve, right? So usually this is commonly seen in cases of fractures or surgeries. Okay, that is the reason why axillary nerve is also known as your surgeon's nerve. If I talk about the motor innervation and the cutaneous innervation of your axillary nerve, so first of all, please remember, axillary nerve innervates two muscles. First is your deltoid muscle and second is your teres minor muscle. First is your deltoid and second is your teres minor muscle. Both of these are innervated by axillary nerve. Next, talking about the cutaneous or sensory innervation of axillary nerve. So please remember, it has a branch known as the upper lateral cutaneous nerve of arm. So please remember, it has a branch known as upper lateral cutaneous nerve of arm. So by the name itself, we can remember that it innervates the skin over the deltoid. That means it carries sensation over the lateral aspect of your arm, right? So important thing is that if there is any injury to the axillary nerve, so the sensation over the lateral aspect, upper lateral aspect of the arm would be diminished. Okay, there would be sensory loss or anesthesia over the skin of deltoid, right? And this is known as your regimental badge sign. This is known as your regimental badge sign, which is usually seen in cases of axillary nerve injury. So first of all, there is regimental badge sign, as there is anesthesia over the skin of deltoid. This is the reason why it is known as regimental badge sign, because this is the place where the soldiers usually wear their regimental badge, right? So regimental badge sign. Along with that, as we know that deltoid muscle is responsible for abduction from 15 to 90 degree. Okay, it is responsible for abduction of the arm from 15 to 90 degree, and as there would be deltoid muscle paralysis, so therefore there would be weakening or there would be loss of abduction of the arm, right? So please remember this. So that is important to be remembered for your axillary nerve. Important one more thing was, questions have been asked if there is any injection that is given on your deltoid muscle, any intradermal or your intramuscular injection which is given on your deltoid muscle, that can also lead to your regimental badge sign, or that can also cause your axillary nerve injury. Okay, so please remember this. Moving further, talking about the important nerve, that is your radial nerve, which is a major branch of your posterior cord. So please remember, radial nerve arises from your posterior cord. And what is the root value? So please remember, the root value of your radial nerve would be from C5 till T1. That means it has contributions from all the nerve roots, C5, C6, C8, C7, C8 and T1. Okay, and that is the reason why it is the largest nerve out of all. So please remember, the largest nerve of brachial plexus is your radial nerve. And radial nerve, in short, we can understand it is responsible for innervation of the posterior compartment of arm, posterior compartment of forearm and the dorsum of the hand. Okay, so almost, please remember, radial nerve is responsible for all the posterior compartment of the upper limb. Okay, so now if I talk about the branches of radial nerve, first of all, the radial nerve is formed at the level of axilla. When it forms in the axilla, it gives away its first branch to your triceps. The medial and the long head of the triceps would be innervated by the radial nerve. Okay, medial and the long head of triceps are innervated by your radial nerve. And the triceps muscle, as we all know, it is responsible for extension of the elbow joint. Okay, triceps are responsible for the extension of your elbow joint. So if there is any injury to radial nerve at the axilla, the triceps muscle will undergo paralysis and the extension of the elbow joint would be affected. Okay, so please remember this, extension of the elbow joint would not occur. Next, if I talk about the further, that radial nerve then goes behind your lateral epicondyle, and okay, at the level of elbow, it gives away 3 branches. Okay, so usually these 3 branches innervate. First is your brachioradialis muscle, second is your extensor carpi radialis longus muscle, and third is your brachialis muscle. So at the level of elbow, radial nerves gives innervation, motor innervation to brachioradialis, extensor carpi radialis longus and brachialis muscle. And all of these muscles are responsible, mainly extensor carpi radialis longus is responsible for causing extension. Okay, it is responsible for causing extension at the wrist joint. It is responsible for causing extension at the wrist joint. So if there is any injury to radial nerve just above the elbow or at the level of elbow, the innervation to these muscles would be affected, and therefore these muscles can undergo paralysis, and that can cause inability to extend the wrist joint, and this condition is actually known as your wrist drop. This condition is actually known as your wrist drop. So this is important, so please remember this. Okay, wrist drop is due to any lesion to the radial nerve above the elbow or just at the level of elbow. So please remember, in high radial nerve injury, usually wrist drop is seen in high radial nerve injury, not in cases of low radial nerve injury. Now let's see why. Moving further, talking about when the radial nerve reaches the forearm, it divides into a superficial branch, which is a sensory branch. Okay, whereas a deep branch, which is a motor branch. So the superficial or sensory branch of radial nerve is responsible for carrying sensations over the it is responsible for carrying sensation over the lateral 2.5 digits. So please remember, previously it was lateral 3.5 digits. Now there is an update that radial nerve is responsible for carrying sensations over the lateral 2.5 digits only till the proximal interphalangeal joint. Only till the proximal interphalangeal joint. This is the update. Okay, over the dorsum of the hand, not on the palmar aspect, only on the dorsum of the hand. Everything radial, it is posterior only. Okay, please remember this. Right. Next, if I talk about the deep branch of the radial nerve, which is known as your posterior interosseous nerve or PIN. Okay, so the deep branch of radial nerve is known as posterior interosseous nerve. This is a motor branch and it is responsible for innervation of all the muscles of the posterior compartment of the forearm, except for, okay, please remember, except for the extensor carpi radialis longus, and the brachioradialis muscle and the unconeus muscle. Okay, so please remember, as we already saw that extensor carpi radialis longus and brachioradialis were given the branches at the level of elbow itself. So in forearm, these muscles are not innervated by the posterior interosseous nerve, right? So please remember this. Now if I talk about radial nerve injury, so this is how you can remember it. If there is any injury to the radial nerve at the level of axilla, therefore there would be paralysis of your triceps nerve, and therefore there would be weakness, there would be inability of extension of the elbow joint. Whereas second, then radial nerve just passes on the posterior aspect of the humerus or via the radial groove. Okay, radial groove also known as the spiral groove. Okay, so please remember, on the shaft of humerus posteriorly there is a spiral groove via which the radial nerve passes by. If there is any injury or a fracture shaft of humerus, that can cause injury to the radial nerve at this place. Okay, so just above the elbow. Over here there would be paralysis of your extensor carpi radialis muscle and all radialis longus, and also to the brachioradialis muscle. That will cause weakening, or there would be inability to extend the wrist. Okay, and that is why there is a wrist drop. Okay, that is why there would be a wrist drop. Please remember this. Whereas if we move further, after the level of elbow, if there is any injury to your radial nerve, mainly to the posterior interosseous nerve, there would not be any wrist drop. Why? Because please remember, only till elbow the branches were given for your muscles which are responsible for extension of wrist. After elbow, there is no such branches which are there is no such branches to the muscle which are responsible for extension of wrist. So after elbow, any nerve injury to the radial nerve, okay, that we call it as a low radial nerve injury, which is mainly to the posterior interosseous nerve, that will not cause any wrist drop. Okay, here there would only be a finger drop. And what do we mean by a finger drop? So please remember, the nerves which are innervated the nerves which are innervated by the posterior interosseous nerve, they are usually responsible for causing the extension of your metacarpophalangeal joint. Okay, and if this nerve is injured and the muscles are paralyzed, there would be inability of extension of this metacarpophalangeal joint. So wrist can extend, but the metacarpophalangeal joint cannot extend, and this is known as your finger drop. Okay, please remember. Now usually please remember, radial nerve palsy is also known as Saturday night palsy, crutch palsy, or honeymoon palsy. Okay, so usually when a person is drunk a lot on a Saturday night, then he rests in this position, just resting his axilla on an armchair. Okay, over there what can be the problem? So there can be a compression at the level of axilla, compressing or injuring your radial nerve. Okay, and that can land up the patient in Saturday night palsy. Due to overuse of crutches also, the same thing can happen, and therefore this is known as Saturday night, crutch, or honeymoon palsy, usually seen in cases of radial nerve injury. Then this is what is a wrist drop due to radial nerve injury, just above or at the level of elbow if there is any injury. And for the wrist drop, we usually use a cock-up splint. For wrist drop, we generally use a cock-up splint, on which questions have been asked. Please remember, on which questions have been asked previously. Okay, so nowadays a dynamic cock-up splint is there, with which movements are also fine. So a dynamic cock-up splint was asked, the image was asked in December 2021 session. Okay, please remember this. Moving further, now talking about an important nerve, that is your median nerve. As we saw, the median nerve is formed by the medial root and the lateral root of median nerve, which arise from the lateral cord as well as the medial cord of your brachial plexus. Now what is the root value of median nerve? So please remember, the root value of median nerve is also from C5 till T1. Okay, the root value is from C5 till T1. Okay, just like the radial nerve. Moving further, now once this median nerve is formed with the combination of lateral as well as medial root, then it will cross the brachial artery. It crosses the brachial artery from lateral to medial, and then it enters the cubital fossa. It is the medial most structure in the cubital fossa. It lies on the medial side. From cubital fossa, it further enters your forearm, and it enters the forearm between the heads of your pronator teres muscle. Okay, it enters the forearm between the heads of your pronator teres muscle. Then further from the forearm, it courses onto the palm. Okay, when it enters the palm, it just enters below the flexor retinaculum. Okay, it enters below the flexor retinaculum. Okay, so please remember, below flexor retinaculum we have a space known as the carpal tunnel. Okay, below the flexor retinaculum we have a space known as carpal tunnel. So actually the median nerve goes into the palm through this carpal tunnel. So if there is any compression at the level of the wrist of the median nerve, it can lead to carpal tunnel syndrome. Please remember, that is what is carpal tunnel syndrome: compression of the median nerve at the level of wrist when it passes below the flexor retinaculum. Right? So please remember, this is carpal tunnel syndrome. Now if I talk about the branches of your median nerve, guys, it has some superficial branches and deep branches, all of which are responsible for innervating the flexors of the forearm. Now median nerve is the most predominant nerve which is responsible for innervating the flexors of the arm, flexors of the forearm. Okay, and the flexion action of the forearm, it is mostly needed in case of laborers, and therefore median nerve is also known as the laborer's nerve. Median nerve is also known as your laborer's nerve. Right, please remember this. Now the superficial branch of your median nerve, it innervates superficial flexors like your pronator teres muscle, flexor carpi radialis muscle, palmaris longus muscle, and flexor digitorum superficialis muscle. Okay, whereas the deep branch of the median nerve, which is also known as your the deep branch of your median nerve, which is also known as your anterior interosseous nerve. So please remember, the anterior interosseous nerve is a deep branch of median nerve, whereas the posterior interosseous nerve is a deep branch of your radial nerve. Right? So this anterior interosseous nerve is responsible for innervating the deep flexors like the lateral half of the flexor digitorum longus, flexor digitorum profundus. So lateral half of the flexor digitorum profundus, the flexor pollicis longus, and the pronator quadratus muscle. By here you can remember that both the pronator muscle, that is pronator teres as well as quadratus, are innervated by the median nerve. Therefore the action of pronation is completely the responsibility of the median nerve. Okay, pronation is completely responsibility of the median nerve. Then if I move further, when the median nerve will enter the palm via the carpal tunnel, in palm it will usually have its motor innervation as well as some sensory innervation. So it gives its motor innervation via a recurrent motor branch, and it usually innervates the muscles of the thenar eminence. Okay, just beneath the thumb. Okay, so please remember, median nerve innervates the muscles of the thenar eminence, and the muscles of the thenar eminence can be remembered by a mnemonic LOAF, where L goes for your first and second lumbricals. Okay, for L goes for your first and second lumbricals. O goes for your opponent's pollicis muscle. O goes for your opponent's pollicis muscle. A goes for your abductor pollicis brevis muscle. A goes for your abductor pollicis brevis muscle, whereas F goes for your flexor pollicis brevis muscle. F goes for your flexor pollicis brevis muscle. Whereas one more thenar muscle is there, that is adductor pollicis muscle. Okay, adductor pollicis muscle is not innervated by the median nerve, whereas adductor pollicis brevis is innervated by your ulnar nerve. It is innervated by your ulnar nerve. So it would be the only muscle which would perform its action in cases of median nerve injury. Right? So please remember this right now. We'll discuss about it further. Whereas if I talk about the sensory innervation or the sensory branch of the median nerve at the level of palm, it would be responsible for carrying sensations over the palmar aspect of the thenar eminence. Okay, so please remember, it is responsible for carrying all sensations over the thenar eminence and also over the lateral 3.5 digits. Okay, also the lateral 3.5 digits from the palmar aspect I am talking about. Whereas from the dorsal aspect, it will carry innervations of the lateral 3.5 digits, but only the tips. As we already saw that radial nerve was carrying sensations till the proximal interphalangeal joint. So over that, above that, the sensations would be carried by the median nerve. So please remember, sensory innervations over the thenar eminence and the lateral 3.5 digits would be carried by your median nerve. I hope this is pretty clear with everybody. Moving further, if I talk about the median nerve injury, so if there is any lesion, a low lesion we can say for the to the median nerve injury at the level of the wrist, then that can first of all lead to wasting of the thenar eminence, and this wasting of thenar eminence is due to atrophy, denervation atrophy. So please remember, there would be atrophy of the thenar eminence muscle first of all. Second, there would be a weak thumb abduction, because the abduction of thumb, okay, the abduction of thumb is the responsibility of the abductor pollicis brevis, and as it is supplied by the median nerve, so it would be affected. There would be weak thumb abduction. Second, there would be weak thumb opposition. Okay, thumb opposition is this one, when thumb lies in the plane which is different from the other all the other digits. Okay, so please remember, this is the opposition of the thumb, which is the responsibility of your opponent's pollicis muscle innervated by median nerve. So if median nerve injury is there, this opponent's pollicis would not work, and therefore the thumb opposition would not be there, right? So as in median nerve injury, the opposition of thumb is also not seen, and abduction of thumb is also not seen. Therefore, there would be a unopposed action of the adductor pollicis muscle. Unopposed action of adductor pollicis, because it is innervated by the ulnar nerve, and therefore the thumb comes to lie in a plane same as all the other digits, and this is what is seen. This is known as the ape thumb deformity. This is known as your ape thumb deformity, right? First thing. Then if I talk about any high lesion to your median nerve, so any high lesion to the medial nerve, there would be all the signs of the low lesions like thenar eminence atrophy, weak thumb abduction, weak thumb opposition, okay, sensation loss over the lateral 3.5 digits and the thenar eminence. Along with that, there would also be the wasting of lateral forearm, because this lateral forearm muscles, as we already saw, that those were innervated by your deep branch of median nerve, that is anterior interosseous nerve. Again, there would be wasting of lateral forearm. Along with that, we can see two important findings, that is a benediction hand or a pointing index sign. Okay, so this benediction hand or a pointing index sign. So whenever we ask a patient to make a fist, okay, whenever we ask a patient to make a fist, usually the first, second and third, mainly the second and third finger, they could not just flex properly. Okay, they could not flex properly, as flexion of these interphalangeal joints is done by the first and second lumbricals. Okay, and as the first and second lumbricals are paralyzed due to median nerve injury, therefore there would be no flexion at these interphalangeal joints, and that is why they remain straight, and this is what is known as a Pope's hand or a benediction hand deformity seen in median nerve injury. And whenever we ask to sometimes only the index finger is affected, and this is what is seen when we ask to flex the or flex the fingers, or we ask the patient to make a fist. Okay, and this is what is known as a pointing index sign. So this is used to assess median nerve injuries. This is known as a pointing index test or a pointing index sign, and this is what is known as a Pope's hand or a benediction hand deformity, right? Then we also use a phalanx test in case of median nerve injury. Just remember, phalanx test is used for median nerve injury, whereas a reverse phalanx test, just like a namaste, it is used to assess diabetic cheroarthropathy. Whereas this is a pen test. Okay, we ask the patient to touch the pen kept above, okay, by this action, and this action is abduction of the thumb, as it is done by the abductor pollicis brevis innervated by median nerve. As median nerve is injured, abductor pollicis brevis would be paralyzed, and therefore the abduction would not be possible. So this is how we check for the median nerve injury via the pen test. Moving further, now talking about the last important nerve, and that is your ulnar nerve from the brachial plexus, right? Now if I talk about the ulnar nerve, guys, please remember, ulnar nerve, as we saw, it arises usually from the medial cord. Okay, it arises from the medial cord of the brachial plexus. And if they ask you about the root value of ulnar, this is very important, guys, and people usually tend to make mistakes over here. The root value of ulnar nerve, some books say it to be C8 and T1 only. Okay, some books say it to be only C8 and T1, but please remember it has some contribution from C7 also. It has some contribution from C7 also. So this would be your best answer. C7, C8 and T1 together. Okay, so some books say C7 should be written in brackets. Some books say anyways C7 would be included. Okay, so better C7, C8 and T1 together would be the best answer for your ulnar nerve root value. If I talk about the ulnar nerve course now, first of all, the ulnar nerve, once it is formed, it passes on the medial aspect of the arm and then just goes or pass behind the medial epicondyle of the humerus. Okay, it passes behind the medial epicondyle of the humerus. Okay, this was given usually as in a picture format. I'll show it to you on the last slide. So ulnar nerve passes behind the medial epicondyle and then traverses into the forearm. It enters the forearm between the two muscles. Okay, it enters the forearm between flexor carpi ulnaris and the flexor digitorum profundus, right? Then it enters the forearm, traverses along the forearm, and it then enters the palm. But it enters the palm over the flexor retinaculum or above the flexor retinaculum. Okay, so it enters the palm above the flexor retinaculum via a space known as Guyon's canal, via a space which is known as Guyon's canal. Okay, so please remember ulnar canal or Guyon's canal is located above, whereas carpal tunnel is located below the flexor retinaculum. Carpal tunnel mein se the median nerve passes, whereas Guyon's canal mein se the ulnar nerve passes by. Please remember this. Okay, then if I talk about the branches of your ulnar nerve, right? So first of all, if I talk about forearm, in forearm usually ulnar nerve innervates two muscles important. First of all, it is the medial half of the flexor digitorum profundus. As we saw, the lateral half of the flexor digitorum profundus was innervated by median nerve or the anterior interosseous nerve, whereas the medial half of FDP is innervated by your ulnar nerve. And it also innervates the name, it says that is flexor carpi ulnaris. Whereas if I talk about the palm, once the ulnar nerve enters the palm from the Guyon's canal, in palm usually it has two branches again, a superficial branch and a deep branch, right? The superficial branch of ulnar nerve will innervate the palmaris brevis and it will also innervate the muscles and as well as be responsible for sensory innervation of the medial 1.5 digits. Okay, so as you can see in this picture over here, ulnar nerve is responsible for the sensation over the medial 1.5 digits. Okay, that is your little finger and half of the ring finger, and also the hypothenar eminence. All the sensations from hypothenar eminence or medial 1.5 digits from palmar as well as dorsal aspect is carried by your ulnar nerve, right? Along with this, now a deep branch of ulnar nerve, it does not have any specific name, just like median or radial nerve. Ulnar nerve ka deep branch, it is a motor branch and it innervates all the muscles of the palm. Okay, this is very important. Please remember, all the 15 intrinsic muscles of the palm or hand are innervated by your ulnar nerve. Okay, and all these intrinsic muscles of hand are responsible for fine movements. Okay, and as these are responsible for fine movements, which are usually necessary when a person plays some musical instruments, that is the reason why ulnar nerve is also known as your musician's nerve. It is also known as your musician's nerve. Right, so please remember this. Along with all the other nerves, you need to remember one important nerve. All the thenar muscles are innervated by median nerve except one, that is that is adductor pollicis. Okay, so please remember, adductor pollicis is innervated by ulnar nerve. Only one thenar muscle, right? Next, if I talk about interossea, ulnar nerve is also responsible for innervating all the interossea. Okay, so please remember, all the muscles of palm, all the intrinsic muscles of hand, adductor pollicis muscle, along with that third and the fourth lumbricals, right? Third and fourth, first and second were innervated by median nerve, whereas third and fourth lumbricals are innervated by your ulnar nerve. And ulnar nerve is also responsible for innervating interossea muscles. Okay, interossea. There are 4 palmar interossea and 4 dorsal interossea. Right? palmar interossei are responsible for causing adduction of fingers. That is why the mnemonic PAD. Palmar interossei responsible for causing adduction of the fingers. This is how. This is abducted fingers. So this adduction action would be caused by palmar interossei, whereas the dorsal interossei would be responsible for causing abduction of the fingers. That is why the mnemonic DAB. Okay, so the dorsal interossei are responsible for causing abduction of the fingers. This is how. Okay, this abduction is caused by dorsal interossei. Right? I hope this is pretty clear. Now if we look into the ulnar nerve injury, if there is any injury to the ulnar nerve above the level of elbow, it would lead to a partial claw hand. Why a partial claw hand is seen? So please remember, as we saw that the third and the fourth umbilical are innervated by ulnar nerve, and as they would be injured, there would be inability to flex the interphalangeal, there would be inability to extend the metacarpophalangeal joint and the flexion of interphalangeal joint. Okay, so please remember, it is due to injury to your third and fourth lumbricals and your interossei. Okay, so please remember, there would be extension of the metacarpophalangeal joint and flexion of the interphalangeal joint. This is how. Okay, this is how would be seen. When we ask the patient to open a fist, that time what happens usually, the fourth and the fifth finger would not be able to open properly. There would be flexion at these fingers. This is what is known as a partial claw hand. Along with that, there would be a atrophy of the hypothenar eminence, right? Median nerve mein there was atrophy of thenar eminence. In ulnar nerve injury, there is flattening or atrophy of the hypothenar eminence, right? Also, there would be some sensory loss, and this sensory loss is over the hypothenar eminence and the medial 1.5 digits, right? From both palmar as well as dorsal surface. If I talk about the ulnar nerve injury at the level of cubital tunnel, okay, if I talk about ulnar nerve injury at the level of cubital tunnel, here the compression of ulnar nerve behind the medial epicondyle lead to a syndrome known as cubital tunnel syndrome, where there would be wasting of all the intrinsic muscles of the hand. Okay, all the intrinsic muscle of hand wasting would be seen. Along with that, we can find a Wartenberg sign. Wartenberg sign is due to injury to the or paralysis of the interossei. Okay, paralysis of the interossei where adduction would not be possible. Okay, so please remember, palmar interossei are affected, and that is why the little finger is not able to adduct properly. Then in cases of ulnar nerve injury, we can also find Igawa test. There are very important tests from orthopedics for ulnar nerve and median nerve that you need to remember. Okay, so please remember these tests that are important. For ulnar nerve, apart from the Wartenberg sign, we also have a Igawa test. So Wartenberg sign, please remember, was for your palmar interossei. It was for your palmar interossei, whereas the Igawa test is for your dorsal interossei. Okay. So Igawa test may we ask the patient to rest the hand over a table and then raise a finger and just move it sideways. The patient would not be able to move it sideways as the abduction function would be affected. Abduction of finger would be affected, and which is the responsibility of your dorsal interossei, right? So please remember, as dorsal interossei are paralyzed, therefore Igawa test would be negative. Igawa test would be positive and abduction would be negative. Next, if I talk about the third important test that is important in orthopedics, that is your Froment's test. So this Froment's test or Froment's sign is also known as your book test or card test. So whenever a patient is given a book to hold or a card to hold, what has happened? The patient would normally should hold it like this, right? The patient should normally use the adduction. Right, so adductor pollicis brevis should be used. Adductor pollicis muscle should be used to hold any object given like this, right? Just a book or any card. But what happens, as the ulnar nerve is injured, the adductor pollicis is not working, and as the adductor pollicis is not working, so therefore the patient tries to hold the book by just the flexion action, by the flexor pollicis brevis. Okay, and this is how we say that there is an ulnar nerve injury, because the Froment's test is positive, the Froment's sign is positive, right? So moving further, just summarizing all of it, the important and major nerves of your brachial plexus and their injuries. First of all, if there is any region to your median nerve that can manifest as ape thumb deformity. Ape thumb deformity is due to inability of abduction and opposition of the thumb, and there is unopposed action of the adductor pollicis innervated by ulnar nerve. So that is your ape thumb deformity. Then second is your hand of benediction, also known as your Pope's hand. In this, usually the index finger and the middle finger, they are unable to flex at the interphalangeal joints because the lumbricals which are responsible for flexion, they are injured in cases of they are paralyzed in cases of median nerve injury. Whereas last is your pointing index side, when only the index finger would be unable to flex at interphalangeal joints. Then next, if I talk about ulnar nerve injuries, guys, the ulnar nerve injuries would lead to a partial claw hand. Okay, so please remember, it is known as a ulnar claw hand or partial claw hand when the medial two digits would not be able to extend properly at the interphalangeal joints. Okay, this is what is known as a partial claw hand. Whereas a complete claw hand is seen, okay, a complete claw hand would be seen when there is ulnar plus median nerve injury, just like in Klumpke's paralysis, right? Important. Whereas in cases of radial nerve injury, there would be a wrist drop because the extension at the level of wrist would not be possible. Important thing is, wrist drop is only seen when there is radial nerve injury at the elbow or above the elbow. Beneath elbow, if there is any injury to the radial nerve, mainly to the posterior interosseous nerve, there would only be finger drop and not wrist drop, right? For ulnar nerve injury, in cases of claw hand or in complete claw hand, we usually use, for ulnar nerve injuries, mainly we use a knuckle bender splint. So please remember, for, okay, knuckle bender splint. For radial nerve injury, we used a cock-up splint. For ulnar nerve injury, we use a knuckle bender splint. At least remember these names, okay? Whereas now, these are the relations that are important. They usually mark at any point of the humerus. They give a humerus, they mark at any point and ask you the nerve relations or the most common nerve which will undergo injury if there is any fracture at the particular site. So if they mark somewhere over here near the surgical neck of the humerus, the axillary nerve actually wounds around the surgical neck of humerus, and that is why in cases of fracture, surgical neck of humerus, there is a risk of axillary nerve injury. Then the radial nerve, as we know, it passes behind the humerus on the spiral groove or the radial groove on the shaft of humerus. So if there is any fracture shaft of humerus, that can lead to radial nerve injury. Important. Next one, ulnar nerve, as we saw, it passes behind the medial epicondyle. Question was in June 2021. There was an arrow on the medial epicondyle and they have asked which nerve lies in relation to the medial epicondyle or this position. So please remember, just behind the medial epicondyle, there is an ulnar groove from which the ulnar nerve passes by. Okay, so any injury to the medial epicondyle can lead to ulnar nerve injury. Whereas in between the cubital fossa, the median nerve passes. So if there is any arrow which is shown in the cubital fossa, they are mainly talking about your median nerve. And median nerve, please remember, it is commonly associated with supracondylar fracture of humerus. If there is a fracture of supracondylar site of the humerus, that can be associated with median nerve injury. Median nerve injury. Okay, please remember this. With this, we come to an end of this session. Thank you so much for being attentive and thank you so much for listening to this session quietly and patiently. Brachial plexus and the nerve injuries are an important aspect of anatomy and orthopedics. Okay, please listen to this carefully and attempt maximum questions regarding this, so it would become easier for you, okay, to just keep in mind this topic. And let's meet in another session with another topic from another subject. Till then, goodbye, good luck, take care.